Dr. Abdel Sayed is El Sayed, I'm sorry, is an epidemiologist and an educator, a physician, public health expert, and a progressive activist. As the youngest health commissioner of a major US city, he rebuilt Detroit's health department after that city's bankruptcy. He ran for governor of Michigan in 2018 on a state level single payer platform. He's a political contributor at CNN and the author of Healing Politics, A Doctor's Journey into the Heart of Our Political Epidemic, as well as the host of the Crooked Media podcast, America Dissected. He holds a doctorate in public health from Oxford, where he was a Rhodes Scholar, and a medical degree from Columbia University. Micah Johnson, MD, is a physician and a healthcare researcher, writer, and policy advisor. Like Dr. El Sayed, he has advised presidential campaigns on healthcare reform and was a health policy fellow in the US House of Representatives in the office of Lloyd Doggett. He's a founding member of Protect Our Patients, a national grassroots campaign of medical students advocating to defend the Affordable Care Act. And he's currently a resident physician in internal medicine at Brigham and Women's Hospital in Boston. And he holds degrees in neuroscience from Yale, at Oxford, where he was also a Rhodes Scholar. Before all of that, before receiving his MD from Harvard Medical School. Sorry, it's a rough night for me tonight. Their book, Medicare for All, A Citizen's Guide, is the subject of their discussion this evening, though for what it's worth, today also marks the paperback release of Dr. El Sayed's Healing Politics as well. We've had many Rhodes Scholars on the town hall stage, physical and virtual, but I'm sure that tonight is the first time we've ever hosted two at once. Please join me in welcoming Drs. Abdul El Sayed and Micah Johnson.
Thank you so much for hosting us, and we're really excited to be joining you at Town Hall Seattle. We really love the idea of a collective space to engage with ideas, and we hope that we'll have the opportunity to share ours about where we are and where we need to go when it comes to healthcare. I want to give some context just to why we wrote this book. Mike and I got to know each other in the course of my campaign for governor in Michigan. And rather ironically, we got to know each other in the context of a political campaign, but both agreed that the proper place to have a conversation about Medicare for All probably wasn't a political arena, but rather in the personal spaces, in the context where people are thinking about their day-to-day lives and the challenges that they face. And rather than talking about state or federal budgets, it's probably better to be situating this in the context of kitchen table budgets and the insecurity that too many people face in the context of their day-to-day lives. And so we wanted to make this an available resource for people to be thinking about the challenges that belie our healthcare system and the opportunities that we have to taking them on. We talk about Medicare for All because we firmly believe that it is the single best approach to taking on so many of the aspects of our healthcare system that are broken. The fact that too many people don't have healthcare coverage at all, the costs associated with our healthcare system in the United States, the fact that we don't invest money in preventing illnesses in our society as we're watching in the context of this pandemic, and so many of the technical challenges in providing and receiving healthcare in America. And so that was the goal for this book. With that, I'll leave it to Micah, who has a front row seat and is an active participant day to day in caring for patients with COVID-19 and can speak to the experience of being a clinician in this moment.
Yeah, thanks again so much for having us. And I think the spirit of Town Hall Seattle very much matches the spirit of our book and why we called it A Citizen's Guide, where the whole premise of our democracy is that we'll be an engaged and informed community. And I think to the extent that our book can contribute to that, that makes us very pleased. And to the extent that there are local groups like Town Hall Seattle across the country that bring people together around these really important ideas, I'm just grateful to be part of it with Abdul. And, I come at this issue of healthcare today, both as an American, as a patient myself, and as a doctor. And when I got to medical school and I saw every day the gap between the rhetoric we have around healthcare, where we're now quite facile at saying that healthcare should be a human right. But in the day-to-day lived experience of doctors and patients, that just is not the case. And one of my goals for this book is to try to bring the conversation about health reform, which is such a big topic and can be pretty abstract, to bring it down to what it means for individual patients, their personal health problems, and the kind of care that they're getting in the system. So to kick off the book portion of the evening, Abdul, maybe I'll hit it to you first for the introduction, and then I'll tell a patient story after you.
Absolutely. Thank you, Micah. I want to read just a bit from the introduction to the book, because it's often, when we talk about Medicare for All, it seems like it's a new idea. But really, it's an idea that has situated itself in the very founding of this country, and one that is frankly founded in the question of what we do to promote the general welfare, which is right there in the preamble to the Constitution. And I'll read to you about the first instance where under that set of goals, the government way back in the 18th century passed a bill that would provide collectivized government health care. As early as 1798, the Fifth Congress passed and President John Adams signed an early attempt by the fledgling republic to promote the general welfare, an act for the relief of sick and disabled seamen. At that time, international trade was vital to the well-being of the United States, although being a sailor was a particularly dangerous trade. To protect its merchant marine, Congress passed the law creating a system of government-run hospitals for seamen, funded by a mandatory tax on their earnings. As science advanced through the 19th and 20th centuries, American government acted as a catalyst to convert new knowledge into broad improvements in general welfare, improving sanitation, putting fluoride in drinking water, ensuring widespread vaccination, funding new hospital construction, and guaranteeing health insurance for senior citizens. Modern healthcare has developed tools that humanity couldn't have imagined in 1787, from vaccines and antibiotics to robotic surgery and targeted immunotherapy. Because of these advances and so many others, nearly 250 years after the people of the United States ordained and established the Constitution, American life expectancy has more than doubled. And yet, perhaps by the standard of our time and the power and wealth of our country, we are yet failing to promote the general welfare. Life expectancy in the United States is nearly 6 years shorter than in Japan, the longest lived country in the world. American infant mortality ranks 55th in the world. American health disparities by race and socioeconomic status are among the world's steepest. Perhaps worse, life expectancy has stagnated, even falling for 3 straight years between 2015 and 2017. Rather than the infectious diseases of the past, the diseases with predilection for the young today are diseases of despair: drug overdose, alcohol misuse, and death by suicide. For the population at large, cancer and heart disease are the top killers. For this mediocrity, Americans pay by far the steepest price for healthcare in the world. We spend 18% of all the money in our economy on healthcare. We are projected to spend over $12,000 per person on healthcare in 2021, double the average in comparable countries, and our costs are increasing rapidly. This is some context, because the question of who we are and who we want to be, I think, is at the core of our politics. And if we are serious about meeting the goals and expectations, the demands of our Constitution, then there's real precedent to be thinking a lot about how we might actually engage healthcare as the human right that Micah so rightly pointed out we're want to talk about as if it's some kind of norm. With that, I'll pass it off to Micah, who can talk a little bit about one of the patients that we interviewed for this book. Her name is Lisa, and about what her experience teaches us about what Medicare for All is and what it could offer.
Yeah, and throughout this evening, we'll talk a lot about potential solutions. Of course, Medicare for All being what we lay out in the book, but it's also important to get the diagnosis right and what is driving the problems in our healthcare system. And we lay out 4. We say that our healthcare is too expensive, it leaves too many people out, it doesn't keep us healthy, and the experience of giving and receiving care is eroding. And the argument that we make in the book to tie this together is all 4 of those problems stem from this central decision to treat healthcare more like a consumer product than a public good. And to illustrate that, let me read you the story of Lisa Cardillo. Lisa Cardillo will never forget her 15th wedding anniversary. After waving goodbye to their 3 children, Lisa and her husband Dominic drove across the state Granville, a few miles from Lake Michigan. They had more than their anniversary to celebrate. Dominic, who suffered a malignant brain tumor at just 33 years old, was 3 years past his cancer diagnosis. After a full year of treatment, including radiation, surgery, and chemotherapy, he was now down to a few MRIs a year to make sure that the cancer hadn't recurred. Eager for a fresh start, the Cardillos were excited for a weekend getaway filled with romantic sunsets, a brewery tour, and a Red Hot Chili Peppers concert. But just as they were about to enjoy the day on Lake Michigan's sandy beaches, Lisa felt a sharp burning in the center of her chest. Then came the crippling nausea and abdominal pain. Though Lisa was 36 years old and otherwise healthy, she knew that something was terribly wrong. The Cardillos knew better than to call an ambulance. Dominic's had cost them $800 when he was first diagnosed. They rushed to the car and started Googling nearby hospitals. When Lisa finally made it into an emergency room, she immediately went into cardiac arrest. With her heart no longer pumping blood, she crashed to the floor. The emergency room personnel started performing CPR then and there. Over the next 9 agonizing days at that hospital, Lisa was diagnosed with a heart attack caused by spontaneous coronary artery dissection, a deadly tearing of one of the arteries that supply blood to the heart. Although rare, this condition has a predilection for young women like Lisa. After her cardiac arrest, she went into heart failure. The doctors put her in a medically induced coma and implanted a heart pump that do the work that Lisa's ailing heart could not. Thankfully, she survived, but that was just the beginning of her ordeal. All of it was extremely expensive. The hospital sent a bill for $185,460. She had to wear a defibrillator vest that was another $5,000 a month. And the Cardillos have insurance. Unlike the 30 million Americans who don't have it, they have health coverage through Dominic's job as an automotive engineer. Before Dominic's diagnosis, they had tried to save on premiums by choosing an insurance plan, the high deductible, meaning they would need to spend more before insurance kicked in. That left them with $12,000 in uncovered medical bills for his care, which they're supposed to pay out of pocket. Owing 10 different medical creditors money they didn't have, they quickly found themselves underwater. Though Lisa and Dominic resisted asking for help, their friends eventually started a GoFundMe page and through an in-person fundraiser to allay their debts. Together, their friends and family raised nearly $8,000, just enough to get them back on solid footing. But when January 1st rolled around, their deductible reset, and they found themselves back on square one paying for Dominic's ongoing treatment. Beyond the financial toll, there was the personal toll. Lisa had spent hours on the phone with various hospitals, clinics, labs, and imaging centers where they owed money, not to mention pleading with their insurance company to cover the costs of this or that treatment. More than once, she'd found herself crying to the faceless insurance bureaucrat on the other end of the line. She told us, quote, "When your medical bills become more stressful than your husband's brain cancer diagnosis, something is not right." Morbidly, Lisa jokes that her favorite bill is the one for cardiopulmonary resuscitation, the manual CPR she got in the emergency room. For $568, the hospital personnel saved her life. But because she hadn't met her deductible, she paid for it out of pocket. "It's the best $568 I ever spent," she said. But should she have had to spend it at all? I really appreciate Lisa sharing her story with us for the book. And I think the reason that we chose her story to kick off our discussion is it shows that even the people who are supposed to be the ones doing well in our system, the ones who have quote unquote good private insurance through their employers, they are suffering too. They're suffering from all the problems that we see in our system. They're suffering from the high prices, the fact that folks are getting priced out of care, and the fact that the experience of trying to give care or receive care in the system has eroded to the extent where the stress of dealing with medical bills met the level of having a life-threatening cancer diagnosis. So as we talk about Medicare for all as a policy, as a doctor, I'm thinking about patients like Lisa. How would her experience be different under a plan like Medicare for all? And how would the experience be different for so many patients who are dealing with similar problems in our current system?
And then, Micah, do you want to walk us through the active ingredients of Medicare for All as well?
Yeah, so let's jump in. What are we talking about under Medicare for All? And on a basic level, what we mean is under Medicare for All, every American would have comprehensive health insurance provided under a single publicly funded plan. And the basic elements of that is, first, you take the current Medicare program. And important to say, first, we'd make the current program better, where anyone who's on Medicare knows that there are holes in the program. There are significant deductibles that folks have to pay before they get access to care. There's a big element of Medicare that's privatized, whether it's through prescription drugs or otherwise. And there are important categories of benefits that are just left out, like vision, dental, and hearing. So the first step is to patch those holes to make Medicare a truly public program that covers a comprehensive set of services at low or no out-of-pocket cost. And then the second thing is to then put all Americans on Medicare. And, you know, the label Medicare for All is important because people know and trust Medicare. It's one of the most popular social programs in the country. And, you know, that's the reason why this universal healthcare program has been framed as Medicare for All. And, you know, the benefits that people know, whether they're on Medicare or family members are on Medicare, the idea is to try to extend that to the entire population, keeping in mind that what that means is doctors and hospitals that are private today would stay private under Medicare for All. It's not a socialized medicine system like the VA in the US or like the National Health Service in Britain. It's a way to make public insurance universal while keeping our private system of doctors and hospitals.
Now, oftentimes when we think about how we get here, right, and how do we achieve Medicare for All, we put the politics, as we started this conversation, ahead of the policy. And we have a whole chapter in the book called Organizing versus Advertising. And I just want to read you a little bit from that part of the book, because I think it's critical for us to understand what's going to get us there. The question is, what will it take to overcome the barriers? Ultimately, what will be needed is a strong political will within the Democratic Party to pursue Medicare for All. Though passage will not require unanimous Democratic support, M4A will need to become a high priority for Democratic voters and their representatives, and popular enough in swing districts to support Democratic legislators who endorse it. This new consensus is necessary to bolster support among legislators who face the possibility of losing their seats if it passes. What would it take to strengthen the consensus on Medicare for All and build the political will for reform? There's only one foreseeable possibility: a popular national movement pushing for Medicare for All. Quite simply, there is no other force strong enough to overcome the partisan attacks and the deep-pocketed opposition from industry. Make no mistake, a public option or Medicare buy-in would need a similar popular movement to overcome partisan and corporate opposition. In fact, the only reform packages that likely wouldn't have to rely on broad public support are incremental reforms that hinge on winning over moderate Republicans or the healthcare industry. That was the strategy for the Affordable Care Act. Although hopes of bipartisanship were ultimately futile, efforts to win over the healthcare industry largely succeeded. But that strategy is not available for a public option or Medicare buy-in because elected Republicans and healthcare industry groups oppose those proposals as well, deliberately lumping them together with Medicare for All and using the same attack lines. This is one area where Medicare for All has a political advantage over more incremental reforms as a policy to organize around. Medicare for All is a simple policy that expresses a clear moral value: healthcare as a human right. And it has the potential to deliver truly life-changing benefits to millions of Americans. Despite its other political vulnerabilities, there is no doubt that Medicare for All has the potential to excite a broad swath of the American public. I want to emphasize this point because I think, you know, there is this in this moment we're sort of in a local minimum of Medicare for All support, but not a general minimum. And what I mean by that is that we are coming off of real excitement over the past year around Bernie Sanders campaigns, both in 2016 and more recently in 2020. And I think people can come out of those campaigns feeling like we've lost. What is missed, though, in that analysis is that, in fact, we have more momentum for Medicare for All now than we've had, frankly, at any time in the past decade, frankly, any time in the past, I'd say 50 years. And because this conversation is moving, because the imminent failures of our healthcare system are showing themselves in people's lives every day, this is actually the moment to keep going. And I say that because I think I hear a lot of sense of defeatedness, and that's exactly what the industry wants us to feel right now. They want us to feel like we tried and we've lost and we might as well move on. But the reality is that we are just getting started, and there is a real responsibility to be picking this question up and moving it in the minds of people across this country. And it's the question is whether or not we can step up against industry lobbying. And just to make it clear, the pharmaceutical industry and the insurance industry are number one and number two in terms of overall lobbying expenditures, to the tune of $4.4 billion with a B dollars over the past 20 years and $2.7 billion over the past 20 years, respectively. They're going to keep spending their money. And that doesn't even account all of the money that they spend advertising to try and dissuade and disinform the public about Medicare for All. The question is, are we able to counteract that with a solid, grassroots-driven, real conversation about the benefits of real reform? And that really is going to be what this comes down to. So with that, I'd love to open the floor to questions if folks have them. We can obviously keep talking about, we could talk about Medicare for All for 352 pages, but would love to be able to answer folks' questions that may have arisen.
Yeah, thank you both so much. If you folks watching, if you do have questions, just throw them in the chat and we will take them up. So I've got one here from Margaret, which I think is kind of interesting given, some of our experiences so far with, most recently Obamacare, which felt like a huge, transition or, change in the healthcare market. And this feels bigger to me in many ways. So she's asking, what do you think about creating regional Medicare for All systems in groups of states, such as New England? Maybe easier to implement than a national system?
So one lesson here is we can look at Canada. So Canada has a national single payer system today. The way that it started was in a single province. And it worked in one province, and then it slowly spread throughout the rest of the country. The other example we can look at is the Affordable Care Act itself, where I'm here in Massachusetts tonight, and where we had Romney Care as the state level reform in Massachusetts, which was then brought to the national stage, rebranded as Obamacare, and became a national reform. So all this to say, there is certainly historical and international precedent for starting on a state level or on a regional level. So I think that is one possible path forward for a reform like Medicare for All. And you have states now, in Washington state for sure, in California, in New York, states that are underway to try to implement this on their own, or as the questioner mentions, in regional blocks. So I think that's certainly a possibility. And I think the important thing is that the same kind of organizing that helps with state single payer efforts also helps with Medicare for All movement. There's very similar sets of ideas, similar interest groups. So I think this the effort kind of counts double. So to the extent that organizers and legislators can work on this at the state level, as they're simultaneously supporting on the federal level, I actually think that gets us further and faster towards making healthcare a human right. So I'm excited to see, and also knowing that this year, those efforts are going to be relaunched in many of these states. I think it's a very positive development.
Yeah, I agree. I ran for governor on a state level single payer platform. I want to offer some of the complexities of doing this. The challenge with state budget financing is that states cannot carry a deficit. And because they cannot carry a deficit, it's really hard for them to be able to finance these big, broad, sweeping kinds of investitures without the backstop of the federal government. That comes in the form of what we call Medicaid waivers, which were frankly facilitated by the ACA, offers the Centers for Medicare and Medicaid the opportunity to offer a state a waiver in terms of the way that they take in their financing, their money for CMS-driven programs. And it allows them to experiment with these kinds of universal healthcare programs in ways that may facilitate it. But without the federal government's backing, it's really hard for states to do. I think the regional state compact is a really interesting one too, because half of the game here is purchasing power, and purchasing power is always greater with the greater number of quote unquote lives that are included in an insurance pool. And so the higher the number of lives, the greater the purchasing power, the higher the capacity to really drive the economics and change the incentives in the system. So I think there's a lot of potential value here, and I think they're parallel processes. We should be pushing them for both at the same time, rather than thinking about one way or the other. We should be thinking about engaging them collectively.
It was interesting to me that you started out by talking about the role of government and creating the common welfare. I think I at least have a perception of at this point in our nation's history that there's just a lot of mistrust in government, and this would be something. So it's having government so intimately impacting our lives. Do you see that as a problem, or do you think that we need to like rebuild trust of government in our society before we're able to fully implement Medicare for all?
Yeah, let me speak to that. I don't know that people mistrust government as much as they mistrust politics, and the reason I make I try and offer that distinction is because if you look at support for programs like Medicare or Social Security, people love them. And those are fundamentally government programs. They don't dress up like government, but they are government. And frankly, when government works well, it doesn't dress up like anything. It just operates in the background doing the thing it's supposed to do. And that's what good government looks like. And I think part of the problem is that we have so politicized everything in this moment that even government is starting to get sucked up under the sort of political polarization of this moment and the negative partisanship that I think is driving such a aggressive form of politicking. Here's an interesting factoid, though, and I really want listeners to chew on this for a second. There was a really interesting poll that was done in swing states in 2020 that asked, how would supporting Medicare for all change your support for a given candidate? And it found that if Donald Trump supported Medicare for all, I know that's mind-blowing to say, but I'm going to say it again. If Donald Trump supported Medicare for all, he would lose a grand total of 2 points. So the point here is to say that negative partisanship, I think, eats and therefore overshadows so much of our conversation about what government can do that I think sometimes we read into this question of distrust of government more a distrust of politics, and then more than that, a negative partisanship, particularly on the part of Republicans. And part of that is that, I hate to say it, but the other insidious variable here that we're not talking about is racism. I think, the question really is, do we believe in offering big, broad, public, truly open and collective government programs to everyone when we know that they're going to cover people whom our public narrative has called undeserving, right? For the past 40 years, we've been living under a governing consensus that was driven really by Ronald Reagan, who told us that government was a bad thing while also telling us that it was a bad thing because it was there to offer undeserving, quote unquote, welfare queens access to resources. Those two things are so intertwined with the kind of distrust of government among Republicans that, when we talk about this question, I think it is really important to call out the impact of racism, racist tropes, racist narratives on whether or not people are willing to invest in big, broad public programs. And frankly, we really ought to be, because they're good for everyone. I have to name check a book, this one right here, by my good friend Heather McGee, called The Sum of Us. And she talks about the way that racist narratives have undercut public support for programs that benefit white people too. And she uses the metaphor, the historical metaphor of the public pools in the 50s and 60s. And when Brown v. Board passed, or was the decision was made, it applied not just to public schools, but to all public provisions. And when Black folks wanted to use the public pools too, instead of allowing Black folks to use the public pools, they just paved them over for everyone. And of course, that really hurt Black kids, but it also hurt white kids, right? Who over the course of one winter go from having an amazing public pool to having nothing, right? And so we've got to be real thoughtful about the way that that racism shapes our public policy in ways that undercuts our ability to provide big, broad public programs and dresses up as, distrust of government.
I'd like to take that question too. I think it's very much on point, where one of the questions that's raised by Medicare for All is, what is the proper role of government in our society? But I think the disagreements here are often overplayed, where one of the things we talk about in the introduction of the book is that there's a very broad consensus. Almost every American thinks that some things should be done by government and some things should be done by private companies. So things like public schools and fire services and roads, there's broad agreement. These are public goods that government should be primarily provisioning. And then on the other side, there are things like clothing and entertainment and consumer products. We're very comfortable that these are things that should be provided by the private market. So really the question is, where should we draw the line? What things should be provided by government and what things should be provided by the private sector? And, there are very strong arguments, and I think people have a moral intuition that healthcare is something that should be treated more like a public good, more like a human right, rather than a consumer product. So that's really what Medicare for All is asking us to do. It's not asking Americans to change their overall outlook on the difference between government and the private sector. It's saying, look, that feeling that you have that healthcare is different is actually true. In a moral sense, healthcare is different from other consumer products. And in an economic sense, it's different from consumer products. And I think what our healthcare system has shown is that if we try to treat healthcare as a consumer product, the market breaks down. You have companies, for-profit companies, that it turns out you can make extraordinary profits without improving people's health. You just charge them a lot when they get sick. And it turns out that's a great business model. And I think the more that people experience that in their own lives, the more acceptance there is for the idea that healthcare is and ought to be treated as something different. To the other piece of your question about trust in government, I do think there's a lot that can be done to improve trust. And my hope is that over the next 2 years in this administration, we can start to rebuild some of that trust as well. And I think the way that the current administration handles the COVID pandemic and the vaccine rollouts will be critical to get people to understand that the government exists to serve the people, and that when the tools of government are used, it can make people's everyday lives better. And my hope is that there'll be more reforms coming down the line to show, whether it's about drug prices or whether it's about health insurance coverage. My hope is that those in Congress and in the White House now aren't afraid to make people's lives better in a very direct and obvious way. I think too often American policymakers try to hide. We make policy almost by absence, like saying the tax break for private health insurance is a great example. That's $250 billion a year, just an extraordinary sum of money. But people don't think that they're getting in a subsidy from taxpayers to get their private health insurance. They think it's on the goodwill of their employer. And I think to the extent that policymakers can show that, yes, this is government taking action, and yes, it is making your day-to-day life better, I think those kinds of programs can build trust and have this snowball effect where people see that this is working and they want to see more of it.
Yeah, great. Thank you so much, both of you. That was really great, really great insights. I have a question here from a viewer. Do you see Medicare for all as an option or as a requirement for all? Seems like having the public option to buy Medicare is more palatable politically than having Medicare truly for all.
Might want to take a first stab?
Sure. So, I mean, in terms of, defining terms, I think when we say Medicare for all and when legislators in the House and the Senate are proposing Medicare for all, it would be a universal program. It's like Medicare or Social Security. People aren't opting in or opting out. It's universal. Everyone's covered. So I think that's what we're talking about as an alternative plan. A different plan would be to do a public option, also called Medicare for all who want it, in one of the presidential candidates. And we have a whole chapter in the book where we go through these different alternatives and how do they measure up. And, we can take the politics and the policy questions separately. Maybe I'll take the policy side and then punt the politics to Abdul. But on the policy side, I think there's a risk of misunderstanding what a public option is compared to Medicare for all. And I think some people think that with the public option, you get the benefits of Medicare for all, but you don't require people into it. But I think that's a mistake. A public option on its own is not a universal healthcare plan. It just takes our current healthcare system and adds one more option. There's no reason to think that itself is going to make healthcare a human right or is even going to get everyone health insurance. So I think we need to be clear about what the limitations are. My view is that adding a public option to the current system would be a significant improvement. There are a lot of things that are beneficial about Medicare for all that can be replicated on a smaller scale with the public option, in terms of, for instance, using the government's negotiating power to get better prices for healthcare. These are things that can be replicated on a small scale. But I think it's dangerous to see a public option as more than it really is. And for the political question, I'll pass it to Abdul.
Yeah, there is a booby trap in that logic that I just want to highlight, which is the fact that there's this concept in economics called adverse selection, which is how insurance programs tend to unravel. And that's that when you have people who really need a service, an insurance service, who are going to use it, they buy that service. And when they buy that service, they increase the cost of that service overall, which then limits the number of people who aren't going to need that service or use that service from jumping in on it, which then leaves fewer people who then subsidize those high users. And then the cost goes up even more. And you end up having this unzipping of a market. Now, what happens in a public option is that you have a government subsidized insurance program. And what a lot of the private insurers who are interested in making a buck are going to do they are going to do everything they can to push the highest cost beneficiaries onto the public plan. And then politically, right, you can imagine the attacks. Republicans are going to look at that and say, wow, look how bloated and expensive government health insurance is. Do we really want to do that for everyone? Do we really want to expand that? It's obvious that the marketplace is so much more efficient, except for what's happening is that the market is cherry picking the best patients, right? And so it's very important for us to be thinking about that and engaging with that. The other problem is this. There is an implicit logic about choice that sits in that question. And I just want to pick that apart for a second. there's this notion, right, that if you like your current plan, you should stay on your current plan. For a lot of those folks who like their current plan, it's because they've never actually had to use their current plan, right? And that's a really, really, first of all, eye-opening and important point, because so often, right, the people who like their plans are the ones who think it's there for them. But when you look at actually having to pay a deductible, like our friend Lisa had to, or having to actually get care for serious pathologies and having to go through a pre-authorization or fighting for reimbursement for your care, it changes people's perspective. And the insurance industry, they profiteer highly on the fact that for most people who have insurance, they're pretty healthy. So they think it's good, even if it's really not that great. The real choice that people want, frankly, is the choice of a doctor. And the biggest gatekeeper around what doctor you get to see is usually your health insurance company, who only lets you go see the doctors with whom they've set up good reimbursement deals. And so they gatekeep on you. And so I think it's important for us to call out the logic that we've been taught to think about the health insurance industry and ask, is that actually the logic that I have? Or is that just the line that's been fed to me over and over and over and over in multi-million dollar advertising campaigns to tell me that I should be fearful of losing the insurance I have? And this is the way that the industry has leveraged its heft and its money to fearmonger about Medicare for All, is to tell you that these are the things you ought to fear, rather than actually you probably ought to fear having to actually use your private health insurance if and when you get sick.
Yeah, and just to keep going on that point a little bit, I think this is one of the ways in which healthcare is different from other consumer products, where when it comes to something that's purely a matter of taste, your favorite restaurant or your favorite food or a special way that people prepare the dish. Yes, there are, people have all sorts of tastes, and people can disagree about what their favorite meal is versus another. In healthcare, it's not really like that. We keep talking about choice of insurance plan, but really what we're choosing is things like, how big do you want your deductible to be? Or how many doctors do you want excluded from your network? Or how big do you want your out-of-pocket cost to be for prescription drugs? Those aren't things that, people have a special taste for, and they really want to have, a high copay for blood pressure drugs and a low copay for cholesterol drugs. It's clear how to make health insurance better. It's you make the out-of-pocket costs as low as possible. You give people access to as many medications, doctors, and hospitals as possible. So, that's just what Abdul says, where it's an ingenious attack line to talk about taking away choice as a description of, instead of choosing between a handful of plans that are going to restrict your healthcare options in all sorts of ways, instead, if you were automatically on a plan where you're free to get the healthcare that you and your doctor agree that you need, and somehow that's supposed to make you have less choice. So I think it's an ingenious attack line. But when we step back and think about what healthcare is, what we really want is to give people access to all the high quality healthcare that they deserve. And to do that, it's quite straightforward how to do it. You have fewer restrictions on care. So I think it is still an important line to take seriously, because it's been brought up in the political conversation so often. But in terms of the substance of Medicare for All, I think it's a really powerful response to be able to reframe the question of choice around the actual medical care that people are getting, which would be expanded under Medicare for All, as opposed to the idea of choosing which restrictions you want in your insurance plan.
Yeah, we're all such good little capitalists, and we've been programmed to believe that choice is the best thing. But yeah, that's insightful. Thank you. I wonder if you can talk a little bit about how differently the pandemic would have looked had we had a nationwide health insurance. We all, I don't know, keep hearing about, well, this isn't, this is one that's happening to us now, but like guaranteed we're probably going to go through another one sometime. So I don't know how much insight you can offer, but what are some like key elements of how this has been handled that you might think that you think might turn out differently?
Let me speak to it from a public health standpoint. I'll leave it to Micah to speak to it from a clinical standpoint. I used to be a health commissioner for a large, very poor city, America's largest city, largest poor, sorry, poorest big city, and one of the things that we sort of take for granted is that the system is what it is. But part of the reason we don't invest in basic public health infrastructure is because there's very little incentive in our system to do that. There are 900 plus health insurers in the country, and those health insurers usually will cover you for some part of your life. And the investment in prevention in any sort really implies that the money you spend today will be recouped over the long term. Problem is that people move between health insurance programs, and so a lot of that investment would be lost. And so there's a collective action problem around investment. In theory, government should be able to pick that up. The problem, though, is that we spend 18 cents on the dollar for every dollar spent in our economy on healthcare as it is. And so there is no real incentive to invest in prevention in our system, and our public health infrastructure has been anemic because of it. I mean, we pulled off a medical miracle in devising safe and effective vaccines, multiple safe and effective vaccines in less than a year. And then it was kind of like we designed a McLaren X1 engine and then dropped it into the body of a Ford Pinto, right? And so the big problem now isn't that we don't have vaccines, is that we can't actually get the vaccines out to anyone because we don't have a public health infrastructure. And that is entirely a political economy problem of where we invest our money. The second point is that because hospitals are run for profit, we had this precarious situation in the beginning of the pandemic, where elective procedures, which are the biggest single profit item for hospitals, were canceled. And so health insurers, while people were losing their insurance to the tune of $15 million, were making bumper profits because they didn't have to pay for that. And then hospitals were in the same time they were preparing and gearing up to fight COVID-19, were also fighting bankruptcy. I mean, it's just a completely precarious situation. And because hospitals are run based on a profit motive, they take the dogma of management consulting seriously. And one of the things that any management consulting will tell you is that you want just-in-time supply chain, that you shouldn't be carrying high overheads of things that you don't know that you're going to use immediately, like PPE, unless there's a pandemic, in which case you don't have PPE and now your nurses are wearing trash bags. So there are a lot of ways that the incentive model and the culture that it's created have left us extremely precarious in the context of a pandemic.
Yeah, and to speak to the clinical side, so part of my work as a medical resident is treating patients in the ICU, some of whom have COVID. And when treating those patients, a lot of what I'm thinking about is what has the last 20 years of their healthcare experience looked like? Because so often it's folks who have gone decades without reliable access to primary care, who haven't had their lung conditions managed or haven't had their heart conditions managed appropriately for decades. And then, of course, when they get this disease, they get sicker. They're more likely to get admitted to the hospital. They're more likely to end up in the ICU. There's more like die. And more often than not, those are on racial and economic lines where those disparities fall. So the fact that our system has failed to provide reliable medical care for the people most at risk of contracting this virus, I think is a real shame, and really led to so much unnecessary suffering during this pandemic. And then zooming out, by now, I fear that we've taken for granted that, of course, during a pandemic, or of course, during a recession, millions of people are going to lose their health insurance. But that's a crazy idea. No other country accepts that. In every other country, before, during, and after the pandemic, We want citizens to have health insurance the entire way through. There is no more important time to have health insurance than in the middle of a public health crisis. And our system set us up for failure. And, I hope that we do build back better from this pandemic. And, the sad truth is that we have about 30 million Americans, even before COVID started, without health insurance, who are not getting proper treatment for their medical conditions. And, I hope this is a wake-up call. There's really no excuse to have anyone without health insurance in our country. And while I'm pleased to see there are some small steps going in the right direction that are being debated in Congress about how to get more people covered, we need to be talking about how to get everyone covered, because we know that this is not the last pandemic. And it's not just about pandemics. There are people that are dealing with chronic health conditions day in and day out, and those people deserve quality healthcare too. And so I hope that the pandemic and just the speed and scale of the suffering that we've seen can act as a wake-up call to really and finally get to the point where we've got everyone with quality care.
Great. Well, that is it for audience questions. But before we end, I just wanted to give you both the opportunity to, make some closing statements, if you'd like, before we end for tonight.
Yeah, just want to thank everyone for joining. And really what we're talking about in the book is overall, it's a message of hope. And it's saying that we can, in this country, we have the resources at our disposal, the financial resources, we have the human resources in terms of incredible nurses and doctors and pharmacists, people who are so passionate about their work. And that if we get the policy right, we can have the best healthcare system in the world, bar none. It is within our grasp. We can do this to make a system where any person living in the country can be guaranteed the best healthcare in the world. And I think that's something that so many people, myself included, find worth fighting for, even in the face of tall odds. And I'm heartened to see the work that's being done on this issue every day. And I'm always pleased when new people come to this cause who are pulled by it. So, I really hope folks who are interested do check out the book. You can go to medicareforallbook.com, or you can go to the bookstore partner for tonight's event. And I hope you continue to think and talk about this issue with your friends and colleagues, because the issue is not going anywhere.
Yeah, I echo that and just remind folks that we are in a tremendous position to move this, but we have to believe that, and we have to decide that we're going to invest our time, energy, and resources in this work. And so our hope with this book was to create a guide that can be leveraged for by folks who believe in this, or folks who are curious and really want to learn. But we know that this is going to be something that has to sit in the hearts and minds of the people, and we need and deserve this, and we have to decide that we're gonna step up and struggle for it, and so I hope that that this is a tool in the direction of achieving it, and I look forward to partnering together in the work. So thank you so much for having us tonight, and really appreciate the opportunity to share more about this book and about this policy, and look forward to hopefully crossing paths potentially in person in the future.
Definitely. Yeah. And I want to thank the audience for watching tonight. Thank you for your questions. If you are interested in getting a copy of the book, use the link in the chat. That'll take you right over to Third Place, and you can pick up a copy there and support a local business. As you said, Abdul, I hope that in the future we'll be able to see you both in person. But until then, I hope that you stay safe and have a great evening.